initiative for the management of these patients. And later on changed because we discovered that when you're just focusing on the glucose, and I think this was seen in the Accord trial back in 2008, is when we realized, as you focus more on just lowering glucose, you're actually increasing mortality for those patients. And now post-era, when it was 2015 and the LEADER trial, the EMPA-REG outcome trials, it's what changed this to what we currently now having as the management for type 2 diabetes. Type 2 diabetes has always been a heterogeneous disease. It's not one condition. It's many biological and pathophysiological processes that are entailed in one patient. And I'm here trying to introduce to 3 patients. You can see we have a patient there who's young and lean, and we have a patient here who's middle-aged and obese, and we have a patient here, number 3, who's elderly and frail. If you remember the first opening line that I had for you of 2 patients who came with the same HbA1c and ended up in different outcomes, this is one of the things that I wanted to highlight for you to see. If you're going to label these patients as type 2 diabetes, then you will be mismanaging them. And as you can see, if you look at the young and the lean, okay, this is the patient who comes to you in the clinic, they are young, they are lean, but you take the HbA1c and you find it's elevated. In clinical context, previously, you would have started this patient on lifestyle and added your metformin and gradually going up. But the question should be, why is this patient? Because once you get the right diagnosis, you'll be able to manage this patient the right way. If it is MODY, you might go the genetics way and find out which gene is affected and treat it effectively. If it is LADA, you might need to do your antibodies, find it, and you might actually need to introduce insulin therapy from the onset. And we have the common one. You know, this middle age with a pot belly, obese, hypertension, they tend to get fatty liver, they tend to get insulin resistance. This one, you now change your modus operandi, and you need to target insulin resistance in this patient. So here you have things like GLPs and SGLT2s that you might use because they tend to actually have severe insulin resistance, and it will help you in managing that patient. And you have the last patient here, diabetes in the elderly. So here you have 2 situations. You have a patient who's been diabetic for quite some time. And you ask yourself, are they insulin deficient? That's the first question you ask yourself. Or number 2, is this a new diagnosis of diabetes at this age? How are you going to approach that? Are you going to rule out malignancy's possibility as a cause? Okay. Is this patient going to benefit from insulin therapy because of depleted insulin reserves over the years? So that is how I want us to think when you're approaching this case. Now, what is really precision medicine? You see, precision medicine brings into context many things. First, I've answered the first question. Do you have the right patient in front of you? Are you giving the right treatment? And number 3, are you giving at the right time? Because those 3 things need to be in order for you to effectively manage this patient well. Remember, if you miss any of those, then you might delay treatment or mismanage the patient not with the right treatment. Now, back in 2018, a Swedish epidemiologist and researcher asked one question: is diabetes one disease? And the question is no. You see, if you take many patients who have diabetes and you cluster them, you'll come to find that they have different phenotypes, they have different biologies, they have different pathophysiological processes that drive the disease. And This was actually published in the Lancet back in 2018. And basically, what she was looking at was to look at certain parameters to stratify these patients into the phenotypes and their treatments and possible complications that could come up. And she looked at quite a number of things. She looked at the antibodies, she looked at the BMI, she looked at the age, and she looked at also the HOMA, which stands for homeostatic model assessment. And that one, she was looking at the beta cell and the insulin resistance. And no, this is more of a research-based classification. But the reason why I wanted to introduce this slide is so that you understand. If you look at all these things, and she clustered all this into the phenotypes and the possible complications that could come up with, and came up with all this. So you have this severe autoimmunity that you know these are patients who most of the time are GADA positive, they're often young. And these patients actually benefit from introducing insulin early. And you also have the primary driver here for the severe beta cell failure. Now, these are patients who come with highest risk for retinopathy because they don't have insulin from the onset. And you also have the other ones for the ones who have the highest risk for kidney disease because they have severe insulin resistance, diabetes. And we have the mild obesity-related diabetes, and the other one, as you can see, which is age-related. The whole purpose of this is you try and stratify your patient phenotypically, you try stratify your patient by the labs you have, and you tend to find out what kind of risk does this patient portend. Are they progressing more to insulin deficiency? Are they progressing more to insulin resistance? What type of complications are they likely to have? And what kind of appropriate treatment are you going to give them? Now, when it comes to precision diagnostics, and I know this is a challenge because all these resources are not available for all of us. The question that you tend to ask yourself is the patient who's in front of you, is insulin present? Okay? If you're asking yourself that question, what test are you going to do? Number two, is this an autoimmune process? And if so, then what diagnostics am I going to do for my patient? And number three, could this be a genetic condition? And if so, what kind of genetic tests are you going to do? And that now guides you for therapy. Because then, if they are insulin deficient, then you know you are going to give insulin. If they are resistant, then you're going to give medications that are going to modify the resistance. And if there is cardiorenal risk for this patient, then you know the targeted therapy that is going to benefit this patient. But I know we face these barriers. And that's the question that we are going to ask today. Because we are coming from a low to middle income countries where such resources are not at the disposal of everyone. And we know that most of these tests are accessed in urban centers as opposed to places like Muranga where I used to work. So I'm going to propose something, a ladder, that you can use to try and fit your patient into a category that you can offer them benefit in terms of treatment. And I know there's a lot of challenge, and when it comes to data, we don't really have much data. We have the training gaps that we are facing in terms of challenges that it comes to making the diagnosis and treatment for these patients. And much of the data we use is actually from the European, from the Americans. We really don't have our own data to back up our centers. Now, what can we do? We can streamline the process, we can enhance training, we can improve communication and best support. We can talk to each other, we can find out what can I use, for example, if you're in Mandera, how can you reach someone who is in the urban centers who can help you make that diagnosis in terms of escalation of care? And this is the tiered precision care that I was actually proposing. You see, at the level where most of us are is level 1. This is where you really don't have the diagnostics, but you have already some information that can help you because you don't need AI. You just need the patient in front of you and a good history. You look at the age of your patient, you look at the BMI of your patient, you look at family history, clinical features, and this clinical phenotyping can help you because is the patient lean, is the patient obese? How rapid progression is it of the disease, okay? What access to diagnostics do you have? Those are the questions you ask yourself at that context, and it can start to help you to actually go up on the pyramid to see what will be effective of the patient. And level 2 is now where you come up with this C-peptide, the antibody testing. The C-peptide is around between 5,000, I think 7,000 shillings in Nairobi. And the GADA antibodies are, I think, between 7,500 to maybe 12,000. So you see, these are things that can help you to actually manage these patients, especially if your suspicion is really high for a different subset of diabetes that you're thinking of. And level 3 is now the genetic testing, you know, the AI, the digital health tools that are available. I can see Dr. Ilov is here. So the genomics, the studies that you can do, especially for MODY patients, these are things that are actually accessible. As much as they are not within the country, you can actually use the resources that we have to actually stratify this patient on, is this a patient who will need genetic testing for you to make a diagnosis, especially for MODY. Now, we've identified the mechanism, and this is actually what precision medicine is. Precision medicine is not equal to genomics. I want you to get that clear. Precision medicine is using all the tools that are available to you, the clinical information, the diagnostics that you have, the treatment options you have, to make you make that diagnosis. And that is the proposal I had for you. Now, start with clinical phenotype, you know, use the affordable available tools, scale appropriately, and you'll be able to not miss this. And this is the last slide. This calls to, it's a call to all of us about what can we do to improve care for patients who have diabetes. I think it's time we really engaged in setting up registries, you know, get this information that we can use now to make decisions based on our findings. For example, if you look at the classification that was proposed by M. Alquist, it leaves out things like type 5 diabetes, which is in our setting, because that study was done in the European centers. But we are finding that there may be another cluster of diabetes that we have in the African and the Asian population that can't fit in the context of what has been proposed by other countries. And we need to share this knowledge that we have, because as we share this knowledge, we tend to enhance communication and bring effective care to our patients. So, what is precision medicine? Precision medicine is not genomics. Precision medicine is using the clinical information, the diagnostics, the risk stratification, and data. Remember, right now, it's not about data scarcity, it's data overload. And we now need to figure out how to use this data that we have to help in, you know, managing our patients, because we have all these tools with us. It's just about how we are going to use it to make decisions that are right for our patient. Thank you so much for listening.
Thank you so much, Dr. Ombui, all the way from Muranga to Aga Khan, and now he's in Mombasa. So thank you for that very interesting talk. Our next talk will be by Dr. Olive Akunga, then we'll have the talk by Dr. Anne Weragu. Dr. Olive Akunga is the EXACOP program director. She's also a physician endocrinologist who works at the Mater Hospital. She's going to be talking to us about the practical value of AI in redefining the pathway of diabetes management. Thank you.
Good morning, everyone. So thank you, Dr. Ombui, for setting the stage in terms of what we'll be discussing. And as you've had, precision medicine in the current landscape of a physician's practice, and in this context, diabetes care, is heavily reliant on certain models of artificial intelligence. And for those of you who attended Prof. Aluoche's talk yesterday, I think he did most of the definitions, which I ended up removing from my slides because I believe now we understand a few of the definition of terms. So we'll be looking at the practical value of artificial intelligence in diabetes care, and precisely looking at, when we talk about AI, we are basically talking about predictive algorithms, where we have a subset of the population that has fed individual level data to a system. Then it goes into what we have been told over the past few days is called machine learning. And from there, it's able to predict the next patient who comes and does not have their data in this system. Can we predict, one, their diagnosis, two, the kind of management they will have, and even in terms of potential complications, as has been mentioned by Dr. Ombui, and then we'll look briefly at implementation challenges in our context. So getting right into it, we are fully aware, and it is undoubtable, diabetes is one of the biggest global epidemics as it stands. What do the numbers look like? And I think Rosie captured a bit of this in her presentation yesterday. The numbers, when you look at them between 1990 and now, we've quadrupled from around 200 million of the world population in 1990, 35 years later, we are talking about 800 million plus, projected to rise even further by 2045. So this is a problem in our hands. When we're talking about 800 million of the world population, how many people are in the world currently? About 8 billion? So when we are talking 800 million, we're talking 10, 11% of the world population. So this is not something we can wish away. Locally, if you look at our heat map in terms of the data that we have registered at the IDF, still central Kenya, you can see they're highlighted in red, and then the other counties as represented, lowest numbers around the northern coast border. And by 2050, we are looking at about 1.8 million Kenyans. Remember, this is based on underestimates. Dr. Mui has said we have information overload in terms of what is feeding these AI algorithms, but is that information for our Kenyan patients? I think by the end of this, we'll be able to answer whether or not we are even ready to adopt this AI in our local context, or are we just feeding off of euphoria and ending up with what the activists are actually calling medical colonialism in the current practice. So challenges in terms of this global epidemic that we are talking about. Under diagnosis, of course, we've heard about access limitations in our counties, our problems being different. We are grappling with lack of medications, national insurance funders that do not work as effectively as we expect them to, leading to suboptimal treatment. Diabetes as a disease context is very multidisciplinary in terms of its comprehensive care. You have patients who need their eyes checked every so often, their kidneys checked every so often, any organ, name it. It is part of the diabetes comprehensive care. Are our patients able to access this? The answer is a majority of them are not able to. And then, of course, the dependence of the management of diabetes on patient behavior. Regardless of how good of interventions we have, whether it is AI, whether it is the incoming entrants like GLP-1s, GIP drugs, SGLT2s, great data as far as potential benefits in terms of good patient outcomes. Can our patients' behavior be counterproductive? So are they following the dietary requirements? Are they following the prescriptive exercise? Remember, we are in an era where we don't just tell them, go and climb stairs, walk, don't sit. As we need to prescribe exercise precisely, and maybe even prescribe gadgets that they need to be able to assist them along the line. So patient behavior dependence, again. So these challenges, how do they feed into all this? And is AI the saving grace? And assume this gentleman in a suit is AI, trying to throw a lifeline to the physician who's drowning in terms of figuring out how best to shepherd their diabetic patient to as good an outcome as possible. So the good thing is at global level, the direction we have now as the diabetes community in terms of approaching AI solutions is based on an IPAES, or IPACE if you like, framework. And I think this makes it very easy for us, particularly in the diabetes field, to be able to interrogate what interventions are available in our local market, and do they actually answer the questions that we are asking as physicians taking care of these patients? So in terms of an ideal AI system, one, can it identify the problem? Precision in terms of diagnosis, okay? So this AI model, is it trained on those basic data subsets that we've heard about? Does it understand the age of the people who have population within Kenya? Is it 20 to 50? Is it 30 to 79? Does that AI intervention you're prescribing to your patient understand our patient level data? Number two, in terms of prediction, is it able to tell this patient has an A1C of 6.3%, cutoff for treatment, most settings would be 6.5%. Is it able to say, yes, truly, this patient, the way they are training, they're pre-diabetic. In another 6 months, they'll probably be diabetic. Is it able to do that? And is that the trend amongst Kenyans, or do most of our population end up going into remission or reversing? And then in terms of assistance, and that's basically walking the patient journey, is it able to do that? Is it able to support structured education in terms of also supporting the patient through the treatment journey, and just generally the support and end-to-end approach? So the strength of incorporating this framework, as we've said, is not just about completing the patient journey, but also giving us data. So if you have an AI intervention that's able to answer all those IPAES elements, then you're able to get data that makes you confident as a clinician that indeed, even if this is an expensive solution, I am proposing either to government, either to medical insurance, or the patients who are paying out of pocket, then I have trust. I am confident that there is value in terms of the benefit, in terms of the cost attached to it. And ultimately, that is what we would refer to as translational success, where you have an intervention that has been able to guide you as a physician. So look at it as a physician's assistant, that you've walked the journey with this particular solution, and it's really you're able to speak in the same language and be on the same page as though you are the one doing all the work. In terms of what we have currently locally, so this is just a nice summary of probably the different modalities that we have. So we have the plate options. I'm not sure whether the pointer is working. But so we have the apps which we recommend to our patients, where they can take a photo of the food on their plate, and automatically, particularly for the patients on insulin, it tells them this is the carb content in the photo that you have taken, and probably adjust based on the insulin to carb ratio that you've given them, adjust it this way, upwards or downwards. So those ones are there. Some of them are even free. Patients are able to use it. The question is, at the back end of that app, where is that data going? Is it being recorded somewhere as African data, or is it still relying on other data to be able to inform? Now, that question is actually on us, because are we tracking, or are we just recommending these solutions without mechanisms in place to make sure that the back end, as much as those machines are learning, it is representative of our own data, or are we just selling out data and not caring about it? Let me give a simple example. When we look at the person running there, the how many people are wearing smartwatches? I know many people have adopted smartwatches, almost half the room. So we now know that all this data, for example, this is a Fitbit for Samsung. This data has been collected in the back end. And now we know there's marketing of what they're calling Hume bands. Where did the Hume bands get all that information from? I know I may sound a bit controversial, but these are just my thoughts, that this data, when we sign off on some of these things, or when you're reloading your phone app, when it's updating the system and so on, are we even looking, or do we have policies in country that look at exactly where this data is going? The Hume band that has evolved from the fitness trackers is a good thing, because we know this tells you you've walked so many steps, this is your heart rate today, this is how you slept. But it's not able to tell you, in as much as your heart rate is good and you do your 10, 12,000 steps every day, you're actually at risk of pre-diabetes or pre-hypertension. So from all the individual data they have collected from across the world, they've now come up with predictive algorithms And shortly we'll see how to be able to tell this individual, in as much as their fitness levels look excellent, they are actually at risk of diabetes, hypertension, osteoarthritis, whatever it is, in the next few years. And now the shift now is from fitness trackers to these things called human bands. So are we keeping up with these trends, or are we being left behind? In a sense that we have a lot of data coming from our population, but the gap there is, are we in control of what is being fed out there? And do we have a say, even in terms of this? Because if you're selling out the data, then you should be a stakeholder in terms of these new applications coming on board. But instead, the data may be used, and it comes back to us so expensively that we still cannot access in terms of interventions that we contributed to, and so on. So, looking specifically at the technical domains of AI in diabetes care, and this is basically traditional AI. So now you may want to listen a bit more carefully, because this sets probably the heart of what we are presenting today, the distinction between AI technology in the care of diabetes. And we've had two major ones fully explored, or rather extensively explored in the context of diabetes management. That is the general AI, or the traditional AI, also known as discriminative AI, and that is what we are calling domain-based AI. Domain-based basically means it answers one question. So if it's diagnosis, it tells you this patient is diabetic. It's just able to do that. It's not able to tell you what treatment they should be on, what complications they are at risk of. It answers one question. And it will either answer prediction and prevention, screening and diagnosis, complication management. So number 1, 2, and 4. But now we have moved from the era of traditional AI. And why we need to be more alert now is because we are in the era of integrated AI, which we otherwise call generative AI, what is highlighted in blue. Now, generative AI is either a savior or a monster, depending on what end of the spectrum it finds you on. Because what generative AI does is it collects all those individual domains we've talked about, and it just does its own thing. In fact, in the tech world, they call it hallucinatory AI, because it just comes up with things based on what has been fed to it. And that's why the insistence is on whether our own data as Kenya, as Sub-Saharan Africa, is actually represented in some of these interventions. Otherwise, we may run the risk, and as we've had in precision, genetics play a big role, socio-demographic variables play a big role, and so on. So are we running the risk of adopting technology that is not representative of the African? And of course, it goes without saying, will it end up being more harmful or being more helpful in terms of not just diabetes, but in terms of all the chronic diseases that we're looking at? Another local example, a few years back when and I don't know whether there are any radiologists in the room, when the AI interpretations were adopted in some of our facilities for imaging that we would do, there was a lot of uproar, particularly from the physicians, where you would send a patient down to CT or MRI, it comes back with an AI interpretation, and it completely is disconnected from the clinical presentation of the patient. And I think there was a lot of push and pull between the clinicians in the ward or in the clinics and the radiologists in the department that, look, this does not make sense. And I gave you a clinical summary, and it was that these AI algorithms were being tested in terms of predicting what this patient could have based on what the images are. Of course, it's been many years since. Now, those diagnostic algorithms have improved. But as we are onboarding them in some of our subspecialties within internal medicine, those are some of the questions that we need to ask. The generative AI, the data that it is giving us, even in terms of monitoring our patients, is it representative of the local picture? And just as a disclaimer, those are not the only two fields of AI, so it's about to get even more crazy. Right now, we are overwhelmed by the generative AI, but there are other things coming up, simulations, heuristics, other things that are basically high-end statistical models being fed into this machine learning. So now is probably when we need to pay attention and even make certain decisions in terms of policies that regulate some of the AI interventions coming into practice. So they are good things. We just need to have our finger on the pulse. So generative models, as I've mentioned, they do use what you would probably describe as sophisticated statistical modeling. So for those of you who've done a bit of research, it's where you do a simple study and you have like a univariate analysis where you're looking at each variable, for example, each independent variable, whether it's age, weight, ethnicity, all those nice things we list, and look at it. In terms of this disease outcome, is it significant? Is it not significant? So simple study, you've looked at that and you've decided, okay, it looks like increase in age is associated with X disease. And then the next step would be to take all those things that you think are significant and others that may not be statistically significant, but clinically, they are significant. For example, death. It may not have significance, but if that one patient died in your clinic, for you it's 100%. So you then put all those in a multivariate model that again generates certain data to be able to tell you, now when I control for this, this is the outcome. So it's similar to what the generative AI does, but now it bases all that on whatever information has been fed to it to come up with those probabilistic or predictive algorithms in terms of informing care in the context of disease outcomes and basically that patient journey that we talked about. So that said, what are we advocating for? Algorithmic fairness, and that's in terms of health equity in the use of AI in diabetes. And when we talk about algorithmic fairness, that question we cannot be asking to the developers of these sophisticated software and interventions. It's a question we're asking to ourselves. So performance disparities. We've said we are collecting a lot of data. We've been talking about registries forever in the country. Those are things we should advocate for because it would be very easy to pick data from a registry and say, look, this is the Kenyan data. Can you compare it with what this machine has learned on to be able to see the way our patients behave from pre-diabetes all the way to that patient in the dialysis unit because of diabetes kidney disease? Is the journey the same for the Swedish patient compared to the patient in Mombasa? Is it the same for the Mombasa patient compared to the patient in Garissa and so on? We have excellent software developers in country and statisticians and so on. So these are actually apps we can develop by ourselves. Yesterday during the research presentation, we were very impressed. We had a medical officer from, I think, Nairobi Hospital, who was teaching us about the use of AI in terms of ECG interpretation and how we need to evolve the kind of medical training we are doing right now to be responsive to the current landscape of medical practice. So are we teaching our residents, our undergraduates, in terms of how to adopt to these AI systems? Because they could be the very ones coming up with this as opposed to adopting technology that is not actually fed on our data. Low digital literacy. How many of us are even comfortable prescribing those things to patients because we may not understand them ourselves? Do you know how that intervention works? Do you know how to feed data into that thing to be able to give you those predictive analytics? So even a challenge on us as physicians in training, do you have the digital literacy it requires to be able to practice in 2026? We keep asking, will AI replace the physician? Will AI replace the physician? Maybe it will replace the physician who doesn't embrace it. Time will tell. Language localization, of course, we don't have the whole population maybe speaking in English or able to understand software language. Are we also advocating at that level? Or are we too quick to reach for the intervention before making sure that the ground is set for it? So are we teaching the digital literacy? Are we sorting out connectivity issue? These are probably policy level, even political issues. Do we have enough Wi-Fi coverage to be able to sort that out and so on? And in terms of integrating this into a fragmented public health system, there are some baseline questions. I won't get into that. We probably need to answer about our public health systems because the whole point, and that brings me to my conclusion, of adoption of this system is that we must have equity in terms of how they are redistributed. So we agree it is reshaping diabetes management and by extension, chronic disease management across board. We now have even the infectious disease experts using those predictive algorithms whenever patients come in, particularly to the ICU. Not every patient is the same. You may have a bad kidney, so we'll titrate for your creatinine, but if you have low albumin, you shouldn't be on the same dose of medication as the patient on the next bed. And ID are utilizing this to be able to also have precision in terms of prescription of these antibiotics and so on. So as a parting shot, the bottom line is technical excellence alone, as we have seen in terms of embracing AI, does not guarantee us success in terms of how we manage our patients. We need to reach for what is called medical justice in terms of incorporating this into our daily practice. Medical justice is basically fairness, ensuring that there's access, social responsiveness in terms of even understanding, culture. I think it was mentioned yesterday, cultural habits and just how society perception is. Are we ready for this intervention? So I leave you with that question and encourage all of us to be part of a conversation, whatever little data you collect. Probably as a society, we can see how to start even small, partner with the software developers, see what it looks like in our context. I think we had yesterday some doctors here are also software developers. What can we do at our level to be able to inform these superior interventions so that we are confident as physicians that they are representative of our own data and we are able to manage our patients safely? Thank you.
Thank you very much, Olive. Indeed, you've given us a lot to think about. As we go back to our practices, our subspecialties, it's time to really think about AI integration into our daily practice. Now, the next speaker I'm going to introduce to you is no stranger to us. She's called Dr. Anne Wairagu, who is also known as the what? The village doctor. I don't know, have you guys ever Googled Gatundu? It does not look like it's in the village. If you've never Googled Gatundu, just look at it. But anyway, Gatundu is in the village. This is Dr. Anne Wairagu. She's a physician, endocrinologist. She's also a member of KAP as well as a member of the Kenya Diabetes Study Group. And she's going to talk to us about sexual dysfunction. Thank you. You're welcome.
Thank you, Irene. I'm from the same county. Good morning. I know some of you came purposely to listen to this sexual dysfunction. I think it elicits a lot of, there's some people who have even consulted me behind the tent. So after this, we shall talk. So the topic was sexual dysfunction, but of importance is that this is a study which was by the members of the Kenya Diabetes Study Group. So it's not the topic of sexual dysfunction, but I'll cover both because we covered both male and female. Moving forward. Sorry, coming from the village, I always have a problem with this thing, okay? Oh, is somebody tell me? Moving forward is where? Oh, okay. So this disclaimer that this presentation contains original research conducted collaboratively by members of the Kenya Diabetes Study Group. The views expressed are those of the authors for scientific discussion only and do not necessarily reflect official position of the KDSG, affiliated institutions, or conference organizer. Patient confidentiality has been maintained throughout. As way of introduction, as I said, some members of the Kenya Diabetes Study Group, we conducted a study which we call it the Arouse study. This was covering both sexual dysfunction in both male and female in 3 heterogeneous sites in Kenya. That was Gatundu, where I work. We had the Aga Khan, and we had the Lions, and you can see one is public, the other one is private, semi-urban, and rural. These are the authors, myself, as a lead author for this. Then we have Dr. Rilwan, Dr. Kelly, Dr. Saira Sokwala, Nicola Zakech, and Boniale, who was our main supervisor. And this was funded by the Kenya Diabetes Study Group. I will present them as 2 separate studies. The first study, which was I was a key author, is sexual dysfunction in Kenyan men with type 2 diabetes mellitus. This is assessing the prevalence and associated factors from a multi-center study. The background is that the male sexual dysfunction is common but under-recognized complication of type 2 diabetes. It adversely affects the quality of life, intimate relationships, psychological well-being, and treatment adherence. And African data remain limited, especially for premature ejaculation and erectile dysfunction. So the aim of this study was to determine the prevalence and associated factors for male sexual dysfunction amongst Kenyan men living with the type 2 diabetes. These are the methodology. This was a cross-sectional study where 393 men with type 2 diabetes were included. We had 2 assessment tools. For the premature ejaculation, we used the premature ejaculation diagnostics tool and the index of premature ejaculation. For the second assessment on erectile dysfunction, we used the International Index of Erectile Function. And the data was collected. We included the socio-demographic data, lifestyle, which included smoking history, alcohol intake, clinical parameters by blood pressures, taking the BMI, and the like. For the data analysis, we did both univariate and multivariate logistic regression. For studied variables, for the ED, the AIF score, if someone scored less than 26, that was defined as having ED. For the PE, a score of less than 12. In the social demographic, as I said, we took age, level of education, marital status, the tobacco intake, for the lifestyle, social health. For the diabetic-related independent variables, it was the type of diabetes, which treatment the patient is on, and the HbA1c. For the data analysis or descriptive statistic, chi-square, feature squares, and the like. What are the results? In this study group, this was a middle-aged population with a mean age of about 58 years. The mean duration of diabetes was 77 months. Majority of our study population were married, and more than 50% they live in urban dwelling. About 80% had at least secondary or tertiary education, and most, since this was a type 2 diabetes population, they were on oral glucose lowering agents. And the common morbidities for this study population is that they had hypertension, overweight, and obesity. What was the prevalence for our study? For the premature ejaculation, we found is quite common. More than a third of our study population had premature ejaculation. So this suggested that the substantial burden of PE among the Kenyan men with type 2 diabetes. When you compare with other prevalence, other places, it lies within this range of 21 to 70, almost 80%. Across studies, this was suspected because there was a differences in the tools, the definitions, and study populations. So the findings for this support routine inquiry for ejaculation symptoms in diabetes clinic. For the statistic of this score of index of premature ejaculation, you can see the score. The median was 13 when the least to the most. So the higher the score for this is a good score. So this, from the summary of this, you can see the median is high at 13, 12. And for the distress score, the higher the score, that means the person is least distressed. So in summary, this shows that in this study population, they had a good preservation of their, in these domains, ejaculation score, sexual score, and distress score. For the summary again for this statistic, when you look at these domains, majority had a strong ejaculation control. The level of satisfaction was high at about 60%, and only 15% of the study population are reported to be highly distressed because of their performance. What are the factors which were associated with premature ejaculation? One, the age, the mean significant for both adjusted and adjusted odds ratio. Having a secondary education, having a high level activity was so shown to be protective, about 50%. And the other risks, the factors, you find the BMI, both overweight and obese. Then a longer duration of diabetes was found to be significantly associated with premature ejaculation. As you can see, for those who had premature ejaculation, they had diabetes for 99 months, whereas those who didn't have, they had 68 months of having diabetes. For the premature ejaculation, in summary, it said the longer duration diabetes was significantly higher. Higher physical activity was found to be protective. Behavior and behavior, that means the behavior and education factors may influence the symptoms of reporting and the risk. These findings support a broader lifestyle-focused diabetes care. What about the index for the erectile function domains? These were 5 domains. We have the erectile function, which you see the median for this study population was 19, with a minimum of between 1 and 230. Orgasmic function score was 7, sexual desire score, intercourse satisfaction score, and the overall score. So what does it, when we analyze this data, we found, which is maybe outside what most people expect, that erectile dysfunction was not as common as most people thought. In this study population, it was only 6% who reported to have erectile dysfunction. And looking at the different classes for the classification of the ejection dysfunction, the erectile dysfunction, the 13 majority only had mild, that is 3.3%, and the least only 1.3% had severe erectile dysfunction. So in summary, 6.1% had erectile dysfunction. This is lower than most of the published international statistics, which ranges between 35 and 75. What are the possible explanations which we thought in this study? That maybe could there be population differences, methodology, cultural reporting, and the true threshold that were used for the different studies. So despite a lower prevalence, ED remains clinically relevant and should be actively screened for. So it doesn't mean because we have said it's not as common, we should not be screening for it. We have tools for that. What about the factors that are associated with ED? Age was initially significant without the adjusted values, but that was lost. Then high physical activity, again protective. BMI, initially on the adjusted odds ratio, it was significant, but it was lost for significant. Then duration of diabetes remains significant for both adjusted and unadjusted odds ratios. So what are the factors? So longer duration, higher physical activity, protective, and the clinical risk may be influenced by vascular, metabolic, neuropathic, and physiological assessment. So it appears that P is more prevalent than ED in this study population. Physical activity is more protective. So we need integrated sexual health assessment, diabetes care. Then sexual function, dysfunction should be addressed proactively rather than waiting for the spontaneous disclosure by the patient. Clinical implication, validated tools are there. We incorporate sexual dysfunction in men, promote healthy lifestyle, adopt multidisciplinary between physicians, neurologists, psychologists, and educators. But study limitation, this being a cross-section study, potential of underreporting, we cannot generalize this study. And because these are self-reported, they could be influenced by recall bias and social disability. Take-home messages for this study 1. Sexual dysfunction is clinically important and under-recognized complication. P is more prevalent than expected. A longer duration was influencing, and physical activity was protective. Let me move to the second study. The main author was Dr. Rirwan. She has presented even internationally. So I'll again go through a summary for the interest of time. So most of the time we focus on the men, but women also have been influenced, and you'll be surprised that the prevalence is actually higher than the men. So the background is as for the male is more prevalent, underreported, and under-researched. And the aim for this study was to highlight the prevalence of female sexual dysfunction and the related factors, and to enhance awareness and promote intervention. The same study design, it was multi-sectional. This post-study population had 421 men. The tool that we used for this study was the Female Sexual Function Index. These are validated 19-item self-reported questionnaire. And there are 5 domains that were assessed. There was desire, arousal, lubrication, orgasm, and pain. Additional data, we picked retrospective extraction for relevant clinical data from the patient's record. The study variables, the FSFI index score of less than 26 was shown that this showed the patient has a sexual dysfunction. For the independent variables, these are the factors that we assessed, and the data analysis was similar to what we did for the men population. So these are the results. The mean age was 51, majority had type 2 diabetes, majority were employed, majority were married, and 50 were postmenopausal. It was an obese population, the mean BMI of 31%. So the prevalence is quite high as you compare with the male. It was about 76%. And as you can see, if you be able to interpret this, then if you look at the first column, the scores of 3, the desire had the lowest score, and you see the cutoff is less than 4.2, and the arousal. Those are the 2 challenges that most of our women had. And we are expecting for the diabetics to have more of the pain, but surprisingly, this study population, the pain was not a main concern for this study population. But you can see the ranges are quite variable. You can see the first one between 1.2 to 5.4. So there's a lot of variability for this score. So you can see this is what the desire and the arousal were the main concern for the female with sexual dysfunction. What about the factor that associated? Age was significantly, and living in an urban population was found to have a challenge. That means the women I treat in Gatundu had a better function than those who go to those stay in Nairobi and the like. So, but you can see the other factors initially, without adjusting the ratio, they were significant, but this was lost after adjusting the odds ratio. In conclusion, this study highlights that is a high prevalence of female sexual dysfunction among women living with type 2 diabetes in Kenya. And there are multiple contributing factors, of which age and urban residence was significant. What are the recommendations? That we need to increase awareness for female sexual dysfunction, implement regular screening. You have seen there's already validated tools which you can use in our study population. So we also need to use management strategies in diabetes management to improve the overall quality of life in this patient. So what is it in a nutshell for the AROUSE trial when I try to combine the 2 studies? Female sexual dysfunctions appears to be more prevalent than the male sexual dysfunction. Premature ejaculation is more prevalent than the erectile dysfunction. There are few data available for both male and female dysfunction in Kenya. Actually, the only 2 studies found among the men were those one done in Kenyatta as thesis by the postgraduate student. Regular screening for sexual dysfunction in both male and female with diabetes is recommended. I want to acknowledge the study participant, the arousal investigator, as you can see, the study assistant, the institution which is Aga Khan, Gatundu, and Lion First Sight Hospital, and the KDSG for funding this study. Actually, this is the first study the KDSG has funded, and you're hoping they're going to fund more. For the artificial intelligence part, you've heard everybody, this is the theme, in keeping with our theme. Normally, when you're doing this research, of course, you have to be as original as possible. But when the AI can be used, for those who are doing their IMED and the MED, I think you're getting it easy than some of us. So, as when you're doing, you have to go to the library, get those hard books, and go through it. So the AI is coming and able to know where to source for this data. When you are making the slides, you can be able to help you to organize your abstracts and slide structuring, then data presentation ideas. Then you can conduct CMAs, you can see how to teach the teaching content development. But personally, I view it strictly as a support tool because you have to be the one driving the process. Thank you.
Thank you very much, Anne. It was very interesting to see that living in the village is low risk for sexual dysfunction. And because you're the village doctor, if you want to prevent for females, you can ask Anne to help you look for somewhere to stay. For men, if you want to prevent premature ejaculation, just buy a treadmill, keep it in your house, and run on it every day. Okay? So thank you so much. I'm going to invite Dr. Eugene Genga. Dr. Eugene. Dr. Eugene was my classmate. I knew him from when I was in first year. I knew him as a basketballer. I am not saying anything else beyond that. He's a physician rheumatologist at the University of Nairobi, and he's going to talk to us about the Kenyan ARSK gout guidelines development. You're welcome.
Thanks, Irene, for that kind introduction. I was actually sent by a Truma Society to give a draft of our gout guidelines, how we've developed them. We hope to release them sometime this year. So we essentially did a bit of evidence background. We based our guidelines based off BSR, EULA, ACR, and NICE, and we've tried to make them Kenyan. And our goal is just to standardize treatment, because sometimes you get a bit of a jam because you find how gout is managed from area to area is a bit different. So we just make sure that at the end of the day, our patients get the best quality care. So in terms of our audience are US physicians, specialists, but we want to go down to the earlier tier, level 2, level 3. If they're able to recognize for us the diagnosis and refer to maybe level 4, 5, where they can be able to start urate lowering therapy as soon as possible, and for level 6 to deal with the complicated cases. So in terms of where we are right now, we are actually stage 3. So we've done the scoping, the evidence review, and the drafting. So now we are left with the last 3 stages, which will sit down as an association, but also we'll learn to involve nephrology. We'll probably involve also cardiology, endocrinology, and also oncology there in that particular segment. Thank you. So in terms of why we need our own guidelines, there's a rising surge in the non-communicable disease from obesity, hypertension, metabolic syndrome, especially in the urban setting. At the same time also, in terms of standardization, I think that's the most important thing, because a very common question I get being asked by my patients is that when I start you on urate lowering therapy, is it for life or is it for a short time? What are our targets? Because at the end of the day, we're not all the same. I liked what Ombui had said in the first lecture about the diabetes, that not all patients are the same. And when we look at gout in particular, especially the comorbidities involved there, that they're not all the same. So in terms of something small on pathophysiology, we all know that it's excessive production of uric acid, and that leads to the inflammatory cascade and everything, and we want to avoid this chronic tophaceous gout. We've done, there's a paper we had done a few years ago with Professor Oyo, where we looked at gout in sub-Saharan Africa. Unfortunately, the time to diagnosis for most patients was 3 to 8 years, and most of them had polyarticular gout. So you can see we're not doing well in terms of getting these patients early. In terms of why it's rising, like we said, there's a lot of communicable issues from obesity, chronic kidney disease, hypertension, or diuretics are there. In terms of age, we rarely see gout in women, so that's common. The analogy we use that before menopause, it's actually more in male than female. After menopause, most likely it won't be a female that'll get there. And for females, actually, their presentations normally are typical. Who has any idea how the females normally present with gout? Any idea? So usually for females, it's actually the hand. Most of the time they get with fingers, swelling. Usually most people know as gout as for the foot, but for females it's more of the hand. And usually they have other risk factors, the obese people, hypertension, diabetes, and then the menopausal age group. So in terms I think I'll skip this one. So in terms of why is gout rising in Africa, I think I'll go back to what Wadago said. I think we should go back to the village life, technically, because we are more and more urban. We are now more urban. We eat more refined carbohydrates. We are not as active as used to be. We eat more fructose, more drinks as there. And that has actually led to a surge in gout. Because before, in fact, in the 60s and 50s, I was not alive, but the thing was that gout was only seen in Africa. And partly because we had our own particular lifestyle. But in terms of why it's also rising, is that maybe improved awareness amongst us, but also, like I said, our paper did Oyo, we found that we had long delays in terms of diagnosis. 3 to 8 years is a very long time, and this was actually across the African subcontinent. So what are the implications of the late diagnosis? Polyarticular, and polyarticular is very difficult because before we are able to get rid of the tophies and before our surgeons intervene and do the tophectomies that may not really work, and that usually is not a very good presentation for our patients. Apart from that, also, remember that they also have the diabetes, hypertension. A lot of patients that take a lot of NSAIDs, so they also have got kidneys at that particular time. So we hope with these particular guidelines that we're able to get people early. That's number one. In terms of target, I think that's the take-home message here, that we actually have to go to a target. So a target usually, if you have just plain gout, is about 6 milligrams per deciliter. It's about 360 millimoles per liter. If you have tophaceous gout, the target is a bit lower, at about 5, which is about 300 millimoles per liter. Something very interesting, of all the arthritis that is around, gout should be the easiest to treat. Unfortunately, if you look at the adherence rates, if you look at also the outcomes, they're not bad. And actually, people who perform well, the centers that perform well, have actually been able to employ nurses as the gout doctor there. And they've been able to push in terms of getting better outcomes. So some maybe to consider going forward, how do we empower nurses to help us especially manage gout. Patient education is something which we'll try and emphasize a lot on. Usually the question that is normally very difficult to answer is, can I take a bit of alcohol? Can I take a bit of nyama choma? And so it's going to be difficult, and really have to tell them. And the problems that our patients should be able to seek out as is not a joint disease. We have, like the paper we did with Prof. these years back, had shown that people with gout in this particular part of the world had very similar events to people outside in terms of increased risk for cardiovascular issues, heart attack. There's a paper from South Africa that I found that 1 in 3 myocardial infarcts were due to high uric acid. There's another paper from Ghana that has showed 1 in 2 patients with strokes actually been caused by high uric acid. So at the end of the day, you should tell the patients that the gout is not just a joint. And you should not just be saying that, okay, I'm okay today, I don't have to take the medicine. And that it's more than the what? More than the joint. So in terms of our presentation, these are they normally present. Usually, because I teach, I usually give the analogy of a gout starter pack. So how when I say gout starter pack, so usually you've been woken up a casualty by a gentleman. He's come with khaki pants or a khaki short or open shoes. He's in pain, swearing he'll never drink alcohol again in his life. and then you'll find a very concerned wife, very concerned wife next to him. So usually you see that particular combination, most likely it's going to be what? It's going to be gout. So apart from the flares and the tophi, radiographical features, once they get this stage of radiographical erosions, we're in trouble there. So I think at the end of the day, is get these patients early, treat them early, we avoid these complications. I think I'll skip. So for this particular slide, education is very important. And one of the questions I keep getting asked is, what would trigger my attack? Okay, so like for me, I give the story to my students of a patient who went to Mombasa and got a gout attack and feels they're allergic to Mombasa. So they ask me, so what is in Mombasa? Very simply, dehydration is number one. Okay. The food here, the sea fish, isn't it? The purines, have a lot of purines there. Alcohol is also here a lot. So you can see there are many things, because one thing which especially for the precipitating factors, that when you come and find, so not everybody who takes alcohol gets actually gout. And I think I like what Ombui said. I think looking at patients individually is actually the way to go, because you'll not be talking to a Muslim lady telling her to avoid nyama choma and avoid alcohol, she comes from Mombasa. You don't actually look at other causes of that particular issue. And then also genetics is something which you need to look into. I know there have been a lot of genetic studies in South Korea, but in Africa, the paper that we had done, they shown that actually the family history of gout is there. And if you find a person below 35, below 40, who has high uric acid, most probably genetics may be playing a role here. And maybe you need to refer them to my colleague over here to assist there. I think I'll skip this one. So I think in terms of the management principles, I think number one, septic arthritis needs to be ruled out. We are still in Africa. Infections is still somewhere there. Remember that with gout, you can also get fevers. So sometimes we assume that every swollen joint is gout, but actually going to get fever. So it's always good to rule out sepsis. Initiate anti-inflammatories as soon as possible. If you're not sure in terms of the kidney function, this may sound controversial, but steroids are actually appropriate there. If they're already on treatment, do not stop, just continue. In terms of the treatment, when you start the treatment for this particular set of patients, you should be able to tell them that usually when we start the regular therapy, sometimes you might get pseudo increase in the uric acid and get attacks at that particular time. So you should be able, I tell my patients that yes, we're starting regular therapy. It's not guaranteed you'll never get another attack, okay? But if it does occur, it is a normal process. You come back, you sort out the pain, but you need to continue the uric treatment. And then again, treat to target. Target. It's not just starting medicine blankly and watching. And education is very important for these patients. So I think in terms of diagnosis, gold standard, joint aspiration. Joint aspiration is the gold standard where appropriate. I think right now there's been an increase in terms of the microscopes. I think UN has one, Aga Khan has one, I think Metropolis has one. So I think actually there's an increased risk or an increased number of these particular microscopes. So where appropriate, aspirate, and then you see if you have the crystals or not. So in terms of if you're not able to aspirate, sometimes use imaging, but imaging should not substitute in terms of aspiration. And those are good history taking for this particular patients. Remember, for history taking, one of the challenges we have with gout is that the symptoms it's a very interesting disease that it's a monoarticular, meaning one joint, and it's migratory and can come today, disappear tomorrow, come another month, come tomorrow. And the challenging thing about gout is that during a gout attack, the uric acid can actually be normal. So you should be able to advise the patient appropriately that yes, it is normal, but we have to retest later, because sometimes it becomes a challenge when the patient comes to see us and we tell them, okay, we need to check again, and it becomes now a back and forth. They said, oh, Dr. So-and-so said I don't have to test, so it's negative. So you need to advise them appropriately. So in terms of diagnostic, if you're not able to aspirate, there's a very nice algorithm developed by Euler in the 2015 that looked at the joints, time, serum uric acid, and also imaging, something which you can use to apply. So I got a simple case here we can turn and apply there. So we have here a 52-year-old male. He's coming with the typical, I say the gout starter pack, big toe, he's in pain. You can see the peak is less than 12 hours, woke him up at night. What's any idea? Why do gout attacks happen at night? Any idea? Any idea? Any idea? And why the toe? They usually say that the toe is the coolest part of the body at night. That's what they say. And that's why you get more attacks around that time at night. So anyway, back to here. So as you can see for a gentleman here, is a couple of risk factors. There's alcohol that is there. He's also hypertensive. He's on a diuretic. For this particular patient, the uric acid is actually high at about 520 micromoles per liter. As you put him on the score, there anything above 8, you get the diagnosis of gout. And you don't have to cram everything. This is all over on the internet. And AI has really helped us. We just have everything over there. So for such a patient, start on the NSAIDs, colchicine, and then from there we initiate our treatment once the pain episode has resolved. For case number 2, the idea was just here to make sure that we also rule out alternative diagnosis, sepsis. Okay, sometimes septic arthritis can be confused. And you see for a particular patient here, a number of risk factors: age, diabetes, CKD, fever, monoarthritis. So don't assume it's gout. Think also other potential, unless it goes about aspiration of the joint where appropriate. And these days, I think if you're not sure, our radiologists can do that for you. I think I got a call from one of our colleagues who's come back. They actually do this a lot very nicely for us. So where appropriate, aspirate. In terms of treatment, we have options of allopurinol or options of bixostat. Not much difference, they all work the same way. About allopurinol, most people don't understand that allopurinol is, the maximum dose is actually up to 900. Some get less 800, they say 900 milligrams. So you can start low. Why we start low is because if we start low and graduate upwards, the risk of getting flares after starting the treatment is actually less than start at a very higher dose that is there. For the febuxostat, it's about 40. Some guidelines go up to 120, but most guys say 80 is safe enough for those patients. And then must cover them with at least colchicine or an NSAID for prophylaxis. Diet I'll discuss later. So in terms of management, NSAIDs are options. Remember that these patients have other issues. So when we present the NSAIDs, remember there's the heart, there's the kidney. Be aware about that. Corticosteroids are options that are there that you can use to help our patients get better as quickly as possible. I think I'll skip this because of time. So indications for urate lowering therapy. The guidelines say more than 2 attacks a year, but it's very unlikely you'll get a patient who sees it for the first time. So most people, I follow Professor Yo's doctrine. The first time you see them, just start them on treatment, usually. Because it's very unlikely they'll tell you they've had a similar attack elsewhere. So if you have evidence of tophi on radiology or clinically, that's somebody who needs to be put on medicine. Any joint damage, renal issues, stage 3, kidney stones or bladder stones, that guys need to be put on treatment as soon as possible. Or very severe, levels about 9 milligrams per deciliter. There are something which is a bit controversial. They say people below 35, they need to start them on something, but that's with the European guidelines. So in terms of our targets, our target is, like I said, 360 for the normal gout. The facious gout, 300. And that's the target which should be doing, and it should be assessed every month to be appropriate to get to the target. So I think I'll skip this for the interest of time. So comorbidities, diuretics are a no-no, so try and find something alternative. Patients with cardiovascular issues, kidney issues, be about that. Obesity, the SGLT inhibitors help us there also in a particular area. Manage the diabetes better for those patients. Remember that the HIV, TB also, drug interactions, the paracetamol is something should be aware of. And also remember with the elderly people, polypharmacy, they get bored of giving them too many medicines. So try and find a way to standardize and keep it as simple as possible. So alcohol, it's a very controversial statement. The take-home message is that all alcohol can give you gout, whether it's the wines, whether it's the spirits, whether it's the barley. Just that barley is higher than the wine, the spirits, and the last is the wine, but they all can give you alcohol. Diet, also remember people from the coastal region have a lot of diet from the sea. Be about that also. Hydration is also important for these patients. And the last thing, physical activity, getting the smartwatches, like what Olive was saying. So I think I'll skip this. So I think this is the last slide. So at the end of the day, we just want to have a standardized pathway for our patients. And standardized pathway means that we have standardized care, same message, not that I say something different, like listen something different, you say something different, the patient gets confused. Because most of our patients are men who have gout and they don't like taking medicine. And they look for any reason not to take the medicine. In terms of protocol, should be set, and the target. And the last one, holistic patient care. We really need to make sure that, remember that gout is not just gout joints. There's more than the joint there. There's heart issues, there's kidney issues, but also try and involve our nurses there. It's something to consider going forward. Thank you.
Hello? Oh, you can hear me? Thank you very much, Eugene, for that. A second reason to move to the village. It was interesting how you brought in the gout starter pack. He said they normally have a shot, isn't it? And open shoes, and a very concerned wife. And if you go to the park, in which car are you likely to find? A Subaru. What color? a blue Subaru. Thank you. So the next person I'm going to invite is Rosie. Rosie was also my classmate. She's the current president of the Kenya Diabetes Study Group. She is also the outgoing chair of KAP Nairobi branch and the incoming SecGen of National KAP. She's going to talk to us about from numbers to action, AI-driven decision-making using point-of-care testing in Kenya. You're welcome.
Thanks, Irene, for the kind introduction. I drive a Subaru, but I'm wearing closed shoes, and I don't suffer from, I've been hydrating. So thank you once again for having me. Now, in the morning, Dr. Ombui talked about precision medicine with regards to diabetes. We need to stop, like Prof. Alot had said, we stop this idea of RCTs because it's generalizing and it's not helping our patients as much as we thought. And Dr. Akunga said AI is good, but you also have to be careful. So if you're caught in the middle, there might be a bit of anxiety of where do we go next? She says it's good, but you also have to be smart about it. And that's why we are here. We need to look at from numbers to action, AI-driven decision making using point-of-care testing. This is a sponsored talk. That's my disclaimer, and those are my disclosures from the other companies I've ever received honoraria from. Now, we talked a lot about the pandemic that is there about diabetes, but I want you to focus on what's going on in the Africa region. It's interesting that when you look at our prevalences, it's as low as 4%, yet we're the ones who have the highest morbidity and mortality. So where are we going wrong? I think majority of it is because up to 60% are undiagnosed. We're walking around minding our own business. People are not even aware that they're suffering from diabetes. So look at what happened when they looked at they went and got a population in India, about 113,000 individuals, because they wanted to talk about how serious this crisis is. And they found just because of picking people randomly, the prevalence of diabetes was 11.4%. But look at the prevalence of pre-diabetes, people we could potentially have reversed 15.3%. But of the 11.4, only 3.6 were achieving, 36% were achieving basic glycemic control. But remember, a patient doesn't come with just one condition, isn't it? They have hypertension, they have cholesterol and all. So you find the numbers even go lower. So we have all this newer technology, we have the medication, but we don't seem to be getting it right. So it's time to step back, start working smart instead of hard. So this is the missing link. And I want you to focus on, if there's one slide you're going to focus on, it is this one. You come and a patient comes to see you. Now, anyone who manages patients in chronic care knows you really should not be seeing this patient monthly. There's no additional benefit. So you see the patient in January, and the next time they're coming to see you in April. In 3 months, so much can happen. If it's a woman, she can be pregnant. If it is a gentleman, anything could have happened. You have got an infection, you could have been admitted, but you never get to know what is going on. So what about if we introduce something called continuous, integrated, personalized diabetes management? What does this mean? That from the time that they are gone for the clinic visit, you suggest to them that we have apps where you can be able to input the data. How many of you have worked in government hospitals and patients come with a whole logbook of their glucose readings? Some of them are so proud because they're showing you sugars for the last 3 months. Do you actually have the time to look and interpret on all those sugars? Realistically, you peruse through, isn't it? So what we're saying is, what if the patient inputs this into an app and you can be able to see the trends? And so like that, you can be able to get real-time data and you don't have to constantly be called, my sugars went to 4, it went to 15, what do I do? Adjust accordingly so that by the time they're coming to the clinic, you know what has been going on for the last 3 months. So what we're saying is, we are teaching our patients, yes, monitor, but are we being smart about it? So why are we not achieving our good clinical outcomes? Part of the problem is 30% is from the patients. One, either they have low health literacy or they're not willing to accept the diagnosis. or the overall cost, the side effects, the cost of the medication tends to be prohibitive. What about the healthcare system? The biggest problem is, I can tell you, when we are sending some of our patients to see the nutritionist, I get messages, I'm told it's been rejected, the patient cannot see the nutritionist. Yet the diagnosis there is diabetes or pre-diabetes. So one of the things I think we should be doing is inviting also insurance to understand why, because it's integrated management. We give medication, we prescribe diet, we prescribe exercise. So why are they not paying for one versus another? And then us as healthcare professionals, we get overwhelmed. I remember when I was working in Kenyatta, we used to see 80 patients. In Mama Lucy, we would see on one day 80 patients, and I'm there with 5 other clinical officers. If you ask me if I remember one single patient, I will not, because it felt like it was clearing and forwarding. So we really need to start to work smarter. And so this is the concept, that one, you tell them as you monitor, log the sugar levels. Then this helps to track what's going on. And you can see it can be able to tell you how has the patient been doing for the last 7 days, 14 days. Now remember, the more that they do, that also gives you an average of how the sugars are. And with that, you can be able to interpret how you're going to manage. So what is the utility of these interactive healthcare platforms? It's supporting you and ensuring you're giving adequate treatment to your patients. A patient is more likely to be compliant if they're seeing their progress. It's like having a report card when you were in primary school and you come and you show, oh my God, I've done so well. And you are happy as a child, your parents are also happy. You actually don't realize that when you're living with a chronic condition, it's actually I see some of my patients dreading. So one lady told me she dresses really well when she's coming to see me, so that in case I'm giving her bad news, at least the way she's dressed might influence how I give her the bad news. Then patient companion, they feel like, you know what, at least I know I'm doing this, some actual progress, and this overall improves the quality of life. Now what happened is that there was a study conducted by Mohan et al. In 2025, and what they did was they took about 29 centers in India, and they actually took 111 patients and said, you know what if we suggested this particular app, we gave you glucometers, and you kept on tracking. What they found, actually within 3 months, there was a drop in A1C because patients could see what was going on. And that actually says something about something called diabetes distress. You're living with a chronic condition, you're constantly suffering, but when you see numbers like this, you get excited. And you don't realize the impact of mental health on our patients with chronic care. And that's why it's amazing when you see there's a reduction in diabetes distress by up to 19.3%. But there's a clincher here. The less you monitor, the less likely you are to see any changes in the blood glucose, in your A1C. So you have to literally encourage your patients that the more you log in, the more likely we're going to see changes. Now this one, I smiled when I was actually going through the data. Who's more likely to benefit from such, the apps, the tech? It's us seated in the room. There are very few 30-year-olds. Okay, I can see from the front here, we are age groups. But it's actually 40 to 50-year-olds, because we are at the perfect intersection of digital literacy and health motivation driven by midlife responsibilities. You will not be able to take care of your children, run your practice if you're not healthy. So the most motivated they found, actually, when we were given the apps and the glucometers, was 40 to 50-year-olds. But when they looked at who is more likely to achieve much success, if you give to someone who is on oral hypoglycemic agents, we don't anticipate much change. But what they found was it was less bulky, less cumbersome, carrying the logbooks and just inputting. But for the insulin users, it was amazing, especially for type 1 diabetes. Why? There was one improved therapy adherence. So for the type 1, we usually recommend carb counting. And the problem is if they're not taught well, and you end up adding doses of insulin, there's a risk of insulin stacking and them getting hypoglycemia. So this actually helps track, and they can be able to figure out what is going on. The other thing that we look at is those people, especially when they have been struggling, because it's not for everyone that they're likely to accept this app. When you have struggled with your sugars, there's a lot of variability. What we found was patients are greatly motivated when they're exposed to this app and actually continuous monitoring, because then they're actually able to appreciate that drop in your blood glucose. And this enhances actually treatment satisfaction. So is this actually being seen across the world? Yes. So in Mexico, there was real world data for type 1 diabetes patients, and they said within the first month actually of using this, combining an app and the monitor, and the patient actually taking consideration of how we want the patient to take charge of their condition, they actually improved. This was also seen in Spain, and you can see majority of them were done in patients actually with type 1 diabetes in who are managing their sugars, because those are the ones who you tell them we need more frequent monitoring. And that was also seen in New Zealand. But this is the thing, most patients do not want hypoglycemia. So the minute they started recording their sugars, were very excited. The problem was, you actually found the bigger problem was the average of events for hyperglycemia. So we've been worrying so much about hypos because we are worried about the macrovascular complications. But unbeknown to us, we are missing so many hyperglycemia events that is why there's progression of your microvascular complications. So I want to propose to you something called the UTOT synthesis. It's a psychology of adoption, when you're actually going to encourage your patients to be able to take up some of these apps. And it starts also with you. I need to convince you so that you can prescribe. So there's a certain expectancy, okay, of a performance of a certain, whether it is an app or it's a glucometer. Is it going to be efficient for me? Then there's a concept of it's quite tedious. Constantly, I check my sugars, I log in. I check my sugars, I log in. But you're telling a patient, listen, I will listen to you if I know you've taken the time to read the numbers and understand. And we always tell the patient, note down when you find there's a spike. It teaches you what works for you, what doesn't. So this removes that data fatigue, and then facilitating these conditions. Before, when we had talked about glucometers, we were like, patients in public hospitals would only come and do their sugars, right, when they come to clinic. And then the companies went ahead and said, you know what if we remove the charge from the glucometers and you only pay for the strips? Question is, why are you still not prescribing the glucometers for the patients? So facilitate conditions so that you can be able to enhance this. And hence, we use patient-reported outcome measures. This is very important when you're analyzing some of your data, but it looks at the usability, empowerment, and engagement of your clients as well as a doctor. We need to move away from the mentality of, I say you do. No. The patient says you advise. Move away from always saying you need to do, you need to do, you need to do. We start becoming coaches at the end of the day. Now, you have the glucometers, you have the apps, right? But then we still want our patients to come and we want to assess. You know, we've been using things like, say, your A1C, okay? And you know the issues that we've had. A1C, when it first came out, was amazing because it gave us an idea of what our sugar control was for the last 3 months. Yes, we've had its issues. If you have anemia, chronic kidney disease, you cannot be able to assess adequately. But you're saying we're still using it in pregnancy as well, in the early trimester, to make a diagnosis. But this is where the problem comes in. You send a patient, they're coming to see you after 3 months. You can't remember whether you gave them a request to come and do the test or not. You send them to the lab, you have 30 patients in your private clinic. They come back after 2 hours, and then you're already on patient number 15, then this one comes. So do you see how you enter your clinic at 8 a.m. and end up leaving at 8 p.m.? we need to start working smart. Hence the concept of a point of care testing, okay? That if you can be able to just with a finger prick, be able to analyze and see, because it gives you the A1C if it's less than 5%, 5.7, no, excuse me, no diabetes, A1C between 5.7 to 6.4, you're pre-diabetic, more than 6.5, you have diabetes. But of course, there are caveats to that. Now, why it's important to use point of care is you can be able to, we need to remove this guesswork of, I think the patient is doing well. Now, I want to tell you about a patient I had. She really liked being praised because, unbeknownst to us, she was also having depression. So she writes 5.6, 6.5, 6.2, should actually record. Then a week later, she comes, she's got an infarctive stroke. She has CKD. She has heart failure, and we're wondering, but her sugars are always good. You do your A1C, it's 15%. So I asked her, you know, this is not an exam. I'm not your teacher. I just need to understand. It's like it feels nice when you say, oh, you've been such a good patient. And that's when we realize patients lie. Hence, this is a quick way of actually understanding what's going on. But of course, there are pros and cons. You'll get your results within 3 minutes. So, as your patient has come to see you, they're in your office, do a quick A1C, right? And you can be able to then remove that guesswork of, okay, we can be able to either adjust upwards or downwards with regards to your treatment. And you can see it allows single visit treatment adjustment, and you can be able to expand it to those people who have limited access. But here are the cons. There's some assay bias, of course, between 0.96 to 0.67. Remember, it's giving you an idea of what it's supposed to be. So don't use it to make a diagnosis, but you can use it to monitor your treatment. Now, there are those silent hemoglobin variants that it will not be able to achieve. But if you could be able to change your treatment accordingly, just by doing a single fingerprint test, wouldn't you want to? So it's just something to think about, that when we want to transform workflow, you have ways of tracking, you have ways of assessing, so remove the guesswork by actually having that point of care in your office, and that way you can be able to ensure dynamic care. So I want you to look at this as a connected ecosystem. If you have your point of care monitoring, then you have your app that people input their blood sugars, their diet, exercise, and you have an empowered provider who's telling you this is how things are going on. Wouldn't you ensure that you're achieving optimal glycemic control and ensuring good quality of life for your patients? So let's start working smart. We had talked about registries. The only way we are going to learn trends, like we realized our patients have ketosis-prone diabetes, but they're not type 1. You understand? The landscape of diabetes is changing so much, and we still don't have enough data even on our patients. So what Roche has done is they've actually come up with, they said, I remember talking to them and said, if you give me only A1C, I keep that point of care. It's kind of a waste of time for me and cost. I said, what if you're able to, one, do an additional point of care NT-proBNP, okay? You're suspecting you have your type 2 diabetes patient, has a bit of lethargy, progressive dyspnea. You had previously done an echo, it was okay. Can you do an NT-proBNP and from that gather what's going on with the patient? You have a patient who has recently traveled, had come from New York, went to Mombasa, went to Zanzibar. They're having some lower limb swelling. You're not too sure. You want to send the patient to casualty. Would you be interested in doing that? Or your patient, I remember we used to have our patients when we were managing them with warfarin purely, and they would come for the INRs. And I think the longest lines you have actually are the patients waiting for the INRs. It's very, very, very frustrating for them. That's why I think when the DOACs came, it was very exciting. But for patients with mechanical valves, don't they still need vitamin K antagonists? And finally, for patients like me who come to Mombasa with cough and fever, running nose, and they've come to your office, I am pretty sure you as physicians, you're like, You have quickly written antibiotics and said go, isn't it? You do a quick CRP and that tells you, because even as you're writing your notes from your offices, taking them to the hospital, that's something to think about. So I want to challenge you that sometimes you send a patient from your clinic at 8 a.m., the hospital is calling you at 6 p.m., you don't even know whether they started treatment, whether the treatment was appropriate or not. If you are a regular physician, diabetologist, you're not doing any procedures. So how else are you going to generate revenue? Even us now, we have to be smart, right? So let's do what needs to go forward. We are able to put food on our table, but we're also able to help our patients. Let's start acting smart. So Prof. Aloch talked about electronic medical records. I wanted to give a final experience. There's a hospital I work with. I go part-time. Oh, I have a lot of time. Can I talk some more? Anyway, so a hospital I went to, and I noticed I'm the only doctor who keeps on writing my notes. And they're like, no, sit down. So from the time the patient walks in, they have an AI app that listens in on the conversation. So you've gone to the electronic medical records, one, and you've seen from the last visit, type 2 diabetes patient, these are the medications, the last A1C. So as you talk, it's transcribing. When you look at the results and you're discussing with the patient, it's transcribing your notes. When you say, these are from my examination, this is what I found, and then this is my recommendation, it even actually orders the tests for you and prescribes the medication. My consultation went from 15 minutes to 5 minutes until I was like, okay, maybe I can spend more time even talking to them. We're so focused on typing that you actually lose that connection that you usually have with your clients. So let's start looking at integrating your electronic medical records, your apps and all, then treat the digital therapeutics like pharmacological prescriptions. It's telling you there's a trend. We notice that this patient, breakfast is always a problem, or 6 p.m. is always a problem, especially for people who are fasting. When they break fast, they eat dates, then they'll snack, and then again they'll have the meal. So you can be able to actually predict what is going on. And then most often, which is where we need to pull away from, is that because we are refusing to learn how to integrate these apps, then you tell the patients it's really not that important, it's expensive. We move away from being the people who are saying, do as I say, and work with the patient. I find majority of my patients stay with me because I choose to be their coach. I say, today, at the first visit, I am your doctor. From the next visit, I am going to be listening. I am like your mental health specialist. I just listen, and where I feel there's a problem, I advise. Start being advisors. With that, I'm done. Thank you very much.
Thank you, Rosie. Don't go too far. I would like to pull my comment about the Subaru people, because Rosie has said she drives a Subaru. It is not the Subaru people who are bad, it is the people who are surrounding them that are bad, okay? I'm happy that you talked about an app that targets the 40 to 50. At this age group and above, you find that many apps tend to target the younger people. Oh, sorry, I should be inviting the people who are presenting, Dr. Wairagu, Dr. Olive, Dr. Ombui. Okay, so as they come, one time I was trying to apply for the Blaze Safaricom app, and he told me, sorry, this app is only available for people below the age of 24. That I was a whole decade older. So, I felt some type of way. So it's good when you have apps that target our age group, like the one Rosie is talking about. Yeah, so that we feel included. Someone is missing. Eugene. Ombui. Where's Dr. Ombui? Oh, sorry, I've seen you. So I would like to invite our audience for our Q&A session. Anyone in the audience? Yes, Prof. Aloch.
Thank you very much, Rosalyn, for excellent presentation. I was interested in a lot of aspects of AI. There are a couple of things. Currently, diabetes is probably one of the most monitored by wearable technologies, and now it's even better with internet connection. And most patients don't like pricking all the time. So probably we should be promoting the non-prick wearable technologies that monitor the blood sugar rather than pricking them all the time. And then when it comes to insulin, there are not enough implantable technologies that inject insulin according to the blood sugar, which is measured by technology. A lot of these patients don't need to come to you, so point of care maybe for the first new patient, but in remote areas like Garissa, you probably need this teletechnology to monitor your patients. And one thing which is not being developed in most places, even in Africa, is retinal imaging, AI, as part of the care for diabetic in Africa as well. And it's in Egypt and in Nigeria, they've developed so much that now there is a standard procedure in all diabetic cases. I hope Kenya, I'm told, there's also an attempt to promote it. And finally, when you talk about precision medicine, you talk about genomics, proteomics, but above all, lifestyle, and nothing requires lifestyle more than diabetes. And this depends on robust EHR, which you must develop before you talk about precision medicine in diabetes.
You're absolutely right. We are actually in the process of working with KRA too. They have a very robust patient registry, which is something we are closely working with the Ministry of Health to be able to set up. Because like you see what Dr. Ombui had said, if we do not know what the landscape looks like, then we cannot be able to advise. So similar, there are those ones who, there are quite a number of patients on the continuous glucose monitors, on the insulin pumps, who can afford. So what we are saying is if they can afford, give them. For those of the ones who cannot afford this continuous glucose monitor, then we still use the basics, but we work smart about it. Before, you'd get patients coming with a fasting sugar log for 6 months, and it absolutely does not help you in any way, because then for the rest of the day, what's going on with that patient? And that is why we noted a rise in the microvascular and macrovascular complications, which is why majority of the patients you find admitted in the ward are patients with diabetes. So what we are saying is we need to stop working hard. Making the patients do testing or fasting does not add any benefit, as opposed to staggering the testing and then recording, because the other problem is us as healthcare providers, we tell them to record and then we don't even look at those logbooks, because honestly it's quite tiresome. So if you can see the trends, it also gives you an idea. So thank you for your comments.
Thank you. Thank you.
Now you need to have the app on your phone so the patient doesn't have to record and bring it to you. And finally, long time ago we were more keen on doing monitoring, like the sugar levels and the rest. But and how you do it doesn't matter. But now what is more important is not so much as the disease outcome, but the quality of life you give to the patient. If your procedure is so that it makes his life miserable, then you're not doing very much for him. You may be just using your laboratory report. You're treating your report, not the patient.
Thank you. Thank you.
Rosie, you'd like to say something before we invite?
Before
Okay.
she says something, can I make a comment? Thank you. Thank you. I want to agree with Professor Loch about going non-prick. But to be more practical, I think I believe that every diabetic patient and even pre-diabetic should be advised to have a basic glucometer. And the good thing about the glucometers that are on the market is that they come with a pen. And with a pen, you can adjust the prick to the extent that even small children who are type 1 don't feel anything. Number two, the machines, including ActCheck by Roche, if you log in the data, and of course, as doctors, we have to teach patients how to use that machine. If you log in the data, it can eventually give you an average for 1 week, 14 days, 30 days, and 90 days. So basically, what we need to do is to let patients have the knowledge. And the apps are there. And they are cheap. Because the machine, a glucometer, I think now is about, those who are selling them, is about 1,500. Those who are giving them free, like Roche, it's actually free. So
Okay.
patients with diabetes, patients who are pre-diabetic, apart from health style, advice, they should have the machine. Thank you.
Thank you very much. Dr. Gitari, you can...
Sorry, Dr. Irene. Just to add on to the conversation, so all that we are saying is true. But when it comes to the context of AI, it is now that excellent individual data and how now we apply it at population level. So it's good, the apps will record this and your client who has a glucometer will come with these readings. But how do we use that patient's data to be able to assist another patient in a different county who doesn't have the same access? So maybe just to add emphasis on the fact that that is where probably the EHRs will come into play, where when they come with that individual level data, we can upload it onto the system. And over time, once we have enough of this individual level data, be able to come up with predictive algorithms. In addition, linking that data with what medications are they on, what complications do they have, what is their quality of life. So like an end-to-end approach, not just in terms of monitoring, but in terms of linking that to treatment, complications, and so on. So that is where now, in terms of having all that to get together, like we were saying, moving away from domains to a non-siloed approach to the care of diabetes.
Hello?
Dr. Gitari.
I have a question. Sorry.
Sorry, let's just have someone else ask a different question because you only have 4 minutes.
Yes.
Dr. Gitari?
Dr. Gitari from Embu. My question goes to Dr. Wirago. It was a nice study, Dr. Wirago, a quick one. Now, there was this cohort of men, 6% who want ED, 20% of women who want ED. How did this cohort get assistant, so to speak? Did you try to find out the cause of the erectile dysfunction? Did you do serum testosterone levels? Were they on that side, beta blockers, for basically those comorbids? Did you explore all that so that the patient ends up getting assisted in one way or the other? And what were the treatment options that you offer these patients? And lastly, ED, even the general population, is a cardiovascular disease risk equivalent. Did you delve into appropriate cardiovascular risk assessment for this cohort of patients? How did it go? Thank you.
Still on ED, Dr. Wirago, before you answer, I'm Professor Wina is my name. My question is that the patients, the people you questioned, who was talking about the ED? Is it the patient himself or is it the partner? And don't you think it was subjective to just if it is the patient who said or the partner? How was it subjective, not objective, when they say somebody has ED?
Thank you for the 2 questions. Is there another one so that I can handle them?
I just wanted to say that it would have been important, especially with the women, to check what women without diabetes reported, because lack of desire and lack of arousal may have a lot of other causes.
Thank you. For Gitari, the study was limited. These are cross-sectional study, and the cross-sectional study already defined what was the aim of the study. First, it was the prevalence and also the associated factors. So by the limitation of that, so we focused on what was our study. So maybe that one calls for another study, which the KDSG will be willing to move ahead, just not to find the prevalence, but this is our baseline. How big is the problem? That's the starting point before we know what is the solution. For, you said about the non-diabetic, I think we are biased, being a KDSG initiated study. We first decided to focus on the diabetic patient, but maybe in future we shall see now between the non-diabetic, how prevalence is a problem. Then the askance of the behind, I didn't even see their face. Or the partner. So it was a self-questionnaire, self-reported questionnaire. So we didn't have the partners, but maybe the partners or that they could be giving a different story, because I think men tend to over-report their prowess in that side.
Yes. Dr. Gitambo, last question, kindly, in the interest of time.
Okay. This one goes to almost all of you. I think this is a fantastic start of the conference. There's AI, looking into AI. We have to move, really. I hope there will be a whole conference about this in the various disciplines. But just one of the algorithms that you're always using, the BMI. Is that BMI you tell us, really? Have you looked into it? Imagine me at BMI 24. How will I look? I think we should time to have a look.
I think we've moved away from body mass index as a surrogate for cardiovascular risk evaluation. We are moving more now to abdominal circumference because BMI doesn't really tell me much. It doesn't tell me about the adiposity, which is a big risk factor, but abdominal circumference is closer. We have also body composition analyzers, which can even now quantify the amount of fat and where it is and adipose and all that. So as much as BMI is still a tool that we use, I agree with you, it's something that is quickly phasing out because there are better metrics to use for assessing such issues.
Okay, thank you very much. I'm sorry we have so many questions. We have to wind up. If you want to ask any more questions during the masquerade dinner, just ask them to identify themselves because you'll not be able to know who is behind the mask. And then you can continue the Q&A. Thank you very much. You can take a photo. As they take a photo, I know you think it is tea break, but we have to invite one of our sponsors. The dinner we had yesterday, for some of you who had dinner here, was courtesy of them. Unfortunately, we finished our AGM very late, and therefore we have to give them this chance because otherwise we will not be seated here in this hall. I would like to invite Mr. Kennedy Otieno from Mivida Homes to give us a small presentation before we can proceed for tea break. Thank you.
Hello, good afternoon. Good afternoon. Good morning. Yeah, my name is Kennedy Otieno from Mivida. We are one of the sponsors of this event. I use the word sponsor with a lot of caution. We are in Mombasa, and maybe some of you might identify by that name at personal capacity. I'm an engineer, but I started off as a medical student for 1 week. So I was in medicine school for 1 week. Then I felt like I had the grades, but I didn't have the calling. So I moved to engineering. So in engineering, the head of department was one engineer called Engineer Peter Okaka. So in just trying to convince me that, and just trying to talk to me that engineering is important, he told me, Ken, anything that was not built by the word, let there be, has been built by an engineer. Even the doctors, anything they use, all machines they use have been built by engineers. We do the MRI machines for them. We do the microscope for them. We build the X-ray machines for them. Even the syringe We design it for them. So engineering is also good. We know you wanted to be a doctor, but engineering is also nice. Okay. So here I am today. I'm a commercial director at Mivida. So let me just take you off from the medical class and just let's talk about real estate, because that's what we do. At Mivida, we design, master plan, and deliver houses. So I want to believe that most of us are familiar with Nairobi. I want to take you through the urban nodes in Nairobi today. So in the Nairobi master plan that we have today that has been executed is the one that was done by the Mzungu before independence. So we've got 3 main urban nodes in Nairobi. That is the CBD. We have Upper Hill, and we have Westlands. And you can see how these hospitals are mapped in these areas. There's a reason. So urban nodes are places where we have a lot of commercial activities. So the CBD is the original predominant commercial center. But then you come to a place like Upper Hill. Upper Hill is heavy commercial, but then there's nothing that happens there at night. Have you tried walking at Upper Hill at 7:30 p.m.? You feel like you're alone. There's no residential, there's no retail, there's nothing. Out of these 3 urban nodes, the most and the well-defined urban node is Westlands, because Westlands has got commercial, has got retail, has got residential, has got institutional, has got healthcare. That's why you'll see, I think Aga Khan is in Westlands, Mpisha is in Westlands, Avenue is in Westlands. If you look at retail, you have your Sarit Center is there, you have all these offices that are there. And it's a place that is fully functional during the day and during the night. You come to a place like Upper Hill, and you look at the feeder roads in terms of that area. You see Ngong Road, you see Langata Road, you see Mbagathi, and most doctors who work in KNH, Nairobi Hospital, Coptic, which are within 2 or 3 kilometer radius, these are people who would want to live around that area. So when we are doing zoning and mapping, we always look at where do we have these urban nodes, and how do they associate with the residential areas that these people would want to live in, so that they've got convenience to their places of work. Someone who, say for example, is a doctor at KNH, teacher at KMTC, for example, they'd want to live along Gong Road. Someone who is at Aga Khan, who works at Aga Khan as a doctor and probably teaches at Aga Khan University, would want to live somewhere along Wayakiwe or somewhere along Limuru Road. So we always look at the roads as well. So talking about the roads, Wayakiwe is the spine of the country, coming from here in Mombasa all the way to Malaba. It's the main artery, rather the main spine of the country. Then we've got arteries like your Ngong Road and these other roads that feed from it. So those are some of the aspects that we look at when we are defining residential nodes within the country. So what have we done as Mivida? Maybe before I get to that, now narrowing down to the residentials, we've always zoned out residential into 3 different densities. There's what we call medium density, high density, and low density. So low density areas are areas with the low people, rather a small number of people per square kilometer. This is your Karen, this is your Gigiri, this is your Roslyn, Runda. Those are low density areas. Medium density, medium number of people per square kilometer. It's your Kilimani, your Kileleshwa, you know. That's the way we've designed residential nodes in Nairobi. And then we've got high density. They're also designed as residential nodes. This is the bulk part of Eastlands is high density. It has been designed as such, whereby you need to have many people per square kilometer, and there's a way that ecosystem works in urban planning, okay? Now, today, if you're doing real estate, you've got to be somewhere along Thika Road, Wayakiwe, Kiambu Road, Ngong Road, or Limuru Road, because those are the residential nodes that interact in most cases with the urban nodes that I've told you. Those are the places where people reside. Today, the population of Nairobi is 5 million people during the day and 4 million people during the night. It means there are people who work in Nairobi, but sleep either in Kiambu, Kajiado, or Machakos. These are the metropolitan counties around Nairobi. So we do a lot of research when you're doing our residential mapping and places where we're putting our houses. So as Mivida, this is what we've done. So why should you listen to me? What have I done? What have we done as a company? This is Garden City. If you've been to Garden City, this is a 47-acre master plan that has been anchored by the mall. That's our project. And the way we do, we master plan it, then we roll it out in phases. So we've now rolled out all this to the tail end of the master plan. So this is 47 acres we bought from EABL, just our neighbors there. and developed houses to completion. In the current strategy period, we've mapped out areas in Nairobi that have got high residential demand, either for people who want to invest or people who want to live in, and those are areas that we have expanded to. Okay. So this is last year where we handed over 494 units to residential to homeowners. So the people who will call you for groundbreaking and they'll never hand over units to you. So I know as doctors, you guys are liquid. Mukona pesa. But where do you take it? Mukona pesa, where do you take it? Because someone will tell you put money in money markets or they'll give you avenues of investment, but how does it work? So one, before you invest, look at the track record of the investor or rather of the developer. What have they done? Do they deliver? Do they deliver on time? What is the quality of the project that they do? Okay? So this, do they hand over? So on my far right, that's our CEO handing over 200 units to IHS. IHS is an international housing fund based in South Africa. It's a PE, it's a private equity fund. What private equity funds do is that they acquire assets, add value, then exit. So they gave us 1 billion Kenya shillings. We built 200 units for them. They took that, now they are holding it for rent for 5 years, waiting for some capital appreciation, then they're gonna exit to the market. So these are homeowners last year who are just getting their houses. So let's spend some time here, just a few. That's more than the time I need, so I'll take less, okay? So this is a master plan of what I'd call a mid-market affordable house. So these are houses ranging from 2 million today to around 10 million for a 3-bedroom. So people came in and bought houses at those prices. Like a studio was going for 1.9 million. Today, that studio is going for 3.3 million, 18 months on. So it means this person has made a capital appreciation of 1.4 million, which is 74% of the investment. That particular studio, and these are actually handed over units, the first phase, is giving them at least 22,000 per month. If you work out that yield, is around 14% per annum. So what am I saying? When you have money to invest, there are different investment vehicles. For someone who bought real estate, for example, that person who bought a studio, they are benefiting in 2 ways. They're benefiting from the capital appreciation. This is the value addition of the product. They bought the unit at 1.9, they're selling it at 3.3. The delta is the capital appreciation I'm talking about. Then the yield is the rental income that they're getting per month, and how does that compare with alternative investments? Someone will tell you invest in commercial government paper, which is the bonds and the, some of these MMFs. They are good. They are also almost risk-free, because the government can never default on its own citizens. It would rather print money and pay you. So if I invest in a government paper today, I'll get a yield of around 11-12%. So 11-12%, that yield is subject to inflation. Today, Kenyan inflation is around 5%. So if I'm getting a yield of 11% from the government paper, and inflation is at 5%, the difference of 11 minus 5 is 6%. That's my actual return, because inflation has eaten away my 5% from my 11. So it's money markets and putting money in bonds is good for capital preservation, not growth of capital. You can preserve it, but it can also be eroded by inflation. On the alternative, if you put your money in real estate from a developer who is solid, who has got a track record of delivering, it means there's a capital appreciation for that particular product because the value of the unit is going up. And what I say is that real estate is inflation hedged. What do I mean? If I'm a landlord today, I'm collecting rent of 30,000 per month. I have my tenant who signed a lease. So I'll tell them, if inflation is 6%, I'll tell them, Mr. or Mrs. Tenant, next year, I'm gonna adjust your rent for inflation. It's not gonna be 30,000, it's gonna be 32,000. The 2,000 is the inflation adjustment. So real estate tracks inflation, and therefore we say it's inflation hedged. Unlike when you put your money in a money market fund, where it's eroded by inflation. Let me give you another example. 2 people, I was here the whole of yesterday and today, because now that was my day 7 of medical school, today day 8 of medical school. I was seeing a patient aged 52, man, etc, etc, etc. So let's say we have, you've got 40 million to invest. there are two people. There's one person who opts to buy land in Karen. Land in Karen is around 50 or so million per acre. Land in Karen is cheaper than land in Tindigua because of the level of density. Karen is low density, I cannot build apartments. So land is cheaper per acre. In Tindigua, I can build a tall building, land is like 200 million per acre. So this person has got 40 million, they've bought half an acre in Karen at 20 million, then they use the other 20 million to build a house of their dream. Sindio? That is person A. Person B has got the same 40 million. They've opted to take 20 studios of 2 million each. 2 million times 20, that's another 40 million. Sindio? So these are two people who have invested the same amount of capital in two real estate products. Now let's look at the return. So let's assume this person who's bought a studio of 2 million, 20 studios of 2 million is getting, let's do some math, is getting 20,000 per month. So 20,000 times 20, 400K, okay? So this person who used this 40 million to get the studios is getting 400,000 every month as a rental income. With this 400,000, he can choose to go and rent the house of that person who built in Karen at even 300K and still have 100,000 to utilize. Now, now 10 years later, let's assume they were 40 years old. When they become 50, this person who lives in Karen, the unit is less than that amount. Rather, the unit is, the valuation of the unit is not so high. And the kids have gone, they've got a lot of bills to pay, and maybe something has just developed around that area and they feel like this is a place I don't want to live in anymore. They can't move. But this person who bought smaller units to give them revenue they can rent out houses elsewhere. And the underlying asset, that is the house, is also appreciating in nature. It was 2 million at the point they bought it. It's probably now 3 million per unit. So his 40 million is now 60 million. So what I'd ask you to do is that invest in Mivida projects, get to preserve capital in real estate, ensure that you classify these real estate developers as people who know what they're doing, people who have delivered good quality, like ourselves. As I wind up, people buy houses for two reasons. One, to invest, two, to live in. People who want to live, that's why in our master plan, we always develop green spaces, then build around them. My good neighbor, I think she's left, she was asking me whether we, other than renders, whether we have actual photos. This is one of our projects. It goes 3 acres of green spaces. The price of land today in Nairobi is very high. Developers are building beacon to beacon. So for us, what we do is that we hive off a whole green space area, have amenities, a gym, a clubhouse, enough parking, a very good gate house, so that people can get to interact with nature. I always believe that as humans, we bounce from the bush. I believe in the evolution theory. And nature is our habitat. You want to see green spaces. Kilimani is a concrete jungle today, and I'm sorry if you live there. There's nothing, kids are playing on the parking lot, they're skating on the parking lot. The moment your child leaves the gate, they're on their own. So what we do is that we acquire land, big land banks, 40, 50, 30 acres. We do a very good master plan, and we develop the houses for you to reside in, and we've got a lot of green spaces. Health and wellness, gym, clubhouse, and all that is all within our projects. This is another one called Kezalaika, next to the UN, along Limuru Road. Same capital appreciation and very high yields. This is a botanical garden that we build in our projects. We don't just give you concrete and 4 walls. We give you green spaces that you can go out and interact with nature. You can run around with your little ones. There are places for even kids. There are places for teenagers where they can ride their bikes and skate. There are places for toddlers where you can entertain your small children. Now, and this is just more of that. This is 2 projects. This is the last slide. These are 2 projects we did ground break on in Riruta, which is just in between Ngong Road and Naivasha Road. Rather, Ngong Road and Wayakiwe. Wayakiwe, being the spine of the country, is very big, recently expanded. Ngong Road recently expanded. These 2 roads are interconnected with the road called Naivasha Road from junction to this other side. So very good road network, construction going on, and I'd like to invite you, as I finish, I'd like to invite you as you take your tea break to our tent behind. I have 2 of my team members. Francis is here, just raise your hand, and Lipta. When you get out, when you get to the booths on your right, you'll see Mivida Homes. So just interact with our people, get to buy our projects, get to interact with us, and thank you so much.
Thank you. Thank you very much for that. I'm sorry, I will not be taking Q&A. Please allow us. I will allow one burning question. One.
There was a lot of anguish in Nairobi because of floods, okay? And we know that Nairobi sits on a river basin. There are three major rivers in Nairobi. Nairobi River, and I think Athi River, not Athi River, Ngong River, and so on. And they drain into Athi River. But within Nairobi, there are about 10 rivers, small ones, which drain into Nairobi River. What I wanted to ask you is, so that our members don't get into anguish, can you tell us that, or can you reassure us that your projects are not sitting in any of those rivers?
Thank you.
Hello. Oh, thank you. That's a very good question. And I was just rushing because of time. So when we design infrastructure, we have, there's a lot of infrastructure that pass along roads and rivers. So all sewer lines are always supposed to flow along the rivers. And the reason why we are getting all these floods, or rather why we are getting all these challenges is, if you look at the way Nairobi has been master planned, the design was done for a certain density, a certain number of people. The sewer line, rather the water, for example, was sized for a certain demand of people. If it's, call it 4 million or 5 million people, the sewer line was sized for a certain demand, same to the power, same to data. But now, due to urbanization, there's been a lot more people coming to Nairobi, but there's been no improvement on infrastructure, especially sewer lines, to accommodate the urbanization. So you'll find a lot of water rationing. For people who live in Nairobi, water is 3 days a week. Sewer lines are bursting because there's been no expansion, and we don't have regular inspection of the same to accommodate the surge of urbanization, people coming to Nairobi. So what we do in our projects is that we ensure that we've got a connection to the main trunk lines, which is your water, your power, your data, and internet, and we've got no flooding concerns. So all our projects, I can assure you that we have taken care of all the infrastructure, and there's no concern. Thank you so much.
Thank you, Nairobians. You have been assured you're not going to swim or canoe to your house. You're going to be woken up by birds chirping. You're going to watch pollination. The bee will be moving from the anther to the filament. Is it the opposite? Yes, so if you have any more questions, you will go to his booth. Now, I'm sorry, I have some sad news. One of our esteemed colleagues, mentors, lecturers, has lost his dear wife. That's Professor Godfrey Lule. So I would like us to stand and honor his wife's memory. He lost his wife today. So I'd like us to just stand in honor of his dear departed wife and observe a moment of silence. Thank you so much. I would like to appeal that we are back in 30 minutes by 11:30. As you visit the booths, please visit our sponsors. You may pass by the banking stands so that you can get loans to buy your homes, pass by the insurance stands, pass by the farmer stands. Thank you so much. I have been your host. My name is Dr. Irene Jerry. See you in 30 minutes. Thank you.
Come on, guys. She did a better job than that. Ebu, as you're walking out, you clap for her. Wasn't she amazing, interactive? Thank you. That's the energy you get from endocrinologists, by the way. You're all invited to join us as endocrinologists at KDSG.